Up next is a 60-minute workshop session on epistemic or testimonial injustice, also going by, unofficially, Team Gaslighting. Our goal is to better understand epistemic or testimonial injustice in healthcare settings, as well as to better understand how to avoid epistemic injustice and experience empowered conversations in healthcare using psychologically informed advanced communication skills. I'm tingling all over. Everybody will have a voice to share experiences and learn collaboratively. This workshop will be delivered in partnership with FisioCamera. Without further ado, your next session.
Can you hear us both?
Loud and clear.
Great.
Hi.
Hi, everyone. So I'm Alison Flynn. I'm a lead clinical psychologist for a neurodevelopmental team in London.
And hi, I'm Ana Leite, and I'm an associate professor in social psychology in Durham University. And I also have lived experience of long COVID, and I've thoroughly enjoyed the conference so far. It's gained so much already. So thank you, everyone.
I'm gonna share the screen. Can you see everyone, the slide moving also?
Beautifully.
Okay, because you can see my levels here. Unfortunately, I don't know what happened, but I hope it's clear anyway.
Okay, great. So I think I'm going to kick us off. Laura, does the slideshow just play as I speak?
Yes.
Yeah,
I will.
Thank you. So one of our colleagues, Diane, sadly couldn't be with us today, so we're going to present some of her thoughts, but we were keen really just to get straight to the discussion. But both Anna and I have long COVID, and we felt that the themes we were hearing so much throughout all of our time together the last 2 days has been about this experience of a need for patient voices, or a need to be understood and believed. So yeah, let's get to it so we can start having that conversation. So the idea of medical gaslighting, it kind of comes in two parts. In the first part, there's an idea of being discredited, that you're not being believed for the suffering in your own body, or for parents not being believed of the suffering of their child's own body. And that the healthcare professional in some way avoids discussing the conclusion of their assessment. And what Diane's point to make here was something around the idea that often there can be an idea sitting behind what's told to the patient, which is the clinician thinks that actually it's a psychological cause of illness, but they won't say that. They might use a phrase like medically unexplained symptoms, for example, but they won't be upfront with the patient about what their conclusion is. Sorry, I've lost my place. Yeah, and I suppose the other part to go with that then is this sense that once you, as the person with long COVID, pushes back, that in turn tends to confirm the suspicion that your symptoms are psychological all along. And usually there's an idea that the gaslighting isn't necessarily an act of malice, and that's something I'll speak to later on from my experience as a clinician. And Diane's research, she has a website, and you can have some links to some podcasts that she's done that I found really helpful to listen to. But one of the things she talks about is this sense that in some healthcare professions, clinicians are trained to avoid the conflict of saying, I don't believe you, it's psychological. And that sometimes the ambiguous language used is deliberate to avoid having that difficult conversation.
And I think this is where I jump in, right?
Yeah.
We don't have slides, so bear with us. So yeah, I mean, I think a lot of the things that we're gonna briefly introduce in this workshop have already been mentioned in other sessions, which kind of make our job easier. But the idea with gaslighting, I think a question that has popped up, especially in the bias session last evening, is whether the experience is the same for everyone, or are some people indeed, or certain groups of people at greater risk of being gaslighted. And I think, this is an important point to discuss, because we know there is systemic bias. And again, last evening's session on bias was really powerful. I think if you haven't had the chance to attend, I really encourage everyone to watch it on replay, because it was really, really good. And we know that there is systemic racism, systemic sexism, and, people are treated differently in all areas of society, in all sorts of settings, based on the sort of social categories that they belong to, or the categories that they are perceived to belong to. And race and gender are obvious one, but there are others like gender identity, age, class, ethnicity, and the list goes on, including levels of ability. And this also happens in healthcare settings. And I think, this was one of the points that one of the panelists made last evening, is that we seem to be surprised that this also happens in healthcare settings. But obviously, bias is pervasive, it's systemic, institutional, it's everywhere. And why does it matter to our discussions about long COVID? Simply because, there's a lot of vulnerability in long haulers, but this means that some people may be at double risk of stigma, let's put it like that. On the one hand, because of having long COVID and this kind of poorly understood condition, and I say poorly understood in society, obviously, in terms of medical research, there's been great advancements. And on the other hand, because of belonging to certain stigmatized social groups or groups that are in general disadvantaged in society. So, it's important to consider that there are different layers to stigma and to potential gaslighting. So these people may be treated differently. Their problems might not be as easily recognized because of other permeating bias. And also they may avoid seeking help. And I think this is really, really important, because they may avoid seeking help because of their negative past experiences or indirect experiences that they've seen others in their community struggling in healthcare settings. So I think privilege is a big word. Is a big word in our society, obviously, but also in health and recovery from long COVID. And, when I say privilege, I'm talking about tangible outcomes, such as financial resources. Obviously, some people are just going to have more money to invest in treatments or try, I know of people who've been to other countries trying all sorts of things. But it's also intangible privilege in the sense that some people may have access to different kinds of social networks, and different support from allies as well. So privilege is something that I think we should take into account when we talk about gaslighting, because certain people may be at greater risk of being gaslighted, and also some people may have fewer resources to resist gaslighting in the first place. And I don't want to paint a very negative picture here, right? I'm not saying that everyone is racist and sexist, and gladly that's not the case, obviously. But we know that it's ingrained in our society, and sometimes it's not very easy to recognize when we sit on the other side of the fence and we haven't been through these kind of experiences. But at the same time, as Alice mentioned, one of the points that she made is that, gaslighting is not usually an act of malice. And in fact, it might result from training that medical and healthcare professionals receive. And in fact, if we are told that it is more likely that people belonging to certain social groups may develop medically unexplained conditions, whether that's true or not, if we receive this training, we might be more prone to recognize these kinds of conditions in certain groups of society, right? But I think as patients, and I now speak more as a patient than as a researcher, but also a bit as a psychologist, I think it's important to kind of think that, not necessarily all doctors or physicians or clinicians are going to be sitting opposite to us and kind of judging us in some way or being biased. I think it's also important to kind of have some sort of, a different mindset when we go into clinic. But there are a lot of social identity, if you like, processes that may permeate even the clinical context. So if we go into clinic and we belong to different cultures or have different backgrounds, we might behave in ways that someone who belongs to a different social category or a cultural background might not easily identify. So, what does it look like to be sick when you're Portuguese or when you're a British person. If we're trying to look at whether someone, and I'm just completely inventing this now because I'm not a physician, if I'm trying to look at whether as an heuristic someone looks pale enough to be sick, and I'm just making it up completely. If you look at someone who has a darker tone skin as myself, it might come across differently. So again, just trying to kind of reframe this as not always being necessarily like, they're not out to get us all the time. And it might just be that certain signs of illness are not easily recognized. And connected to this, I know I'm rambling a bit, but connecting to this, there might also be different social norms in different communities about being vulnerable in this kind of spaces. And I think this is a big one, right? So certain social groups in society, they face all sorts of discrimination and also glass ceilings around, particularly in the workplace, right? And sometimes some people may be, some communities may be judged when they are not even strong or when they are showing vulnerability because of preconceived ideas and stereotypes. So, I'm just going to give the example of women in the workplace. For example, if we kind of try to assert ourselves, or, if you try to be pushed to be heard, we might easily, and I'm sure a lot of you will resonate with this, we might easily be labeled as pushy or bossy or even sensitive when we try to assert ourselves. So there's a lot of processes that go into this that have to do with, to a certain extent, different groups in society and how we are trained to recognize different signs in different groups, or the familiarity that we have even with different communities. But a more general point, obviously, there's a lot of vulnerability in all long haulers, depending or not with these added layers and nuance and vulnerability based on the communities that we might belong to. But there's a lot that feeds into this, obviously, generally processes of identity loss. I think this has been discussed also in this forum. So the idea that the way that we used to see ourselves before COVID in terms of having a professional identity, someone was mentioning yesterday, having credibility, and sometimes this can be lost after developing long COVID, but also, having an able body identity, being able to do all this stuff that we were used to do. Sports identity. There's been people who said, even yesterday in one of the sessions, I used to be an athlete and now I can't even exercise. This is certainly my case as well as a former rower. And, there's a lot of loss and grief that goes into this process as we navigate recovery. That also feeds into our sense of vulnerability, even when we go into the healthcare setting, because people are debilitated to a degree that is, it's quite compromising and shows up in different contexts. It's the same with social isolation. Everyone tells us that, we're supposed to be socially connected. This is good for health. This is good for everything. But obviously the mere nature of the condition, with post-exertional malaise and fatigue being the key symptoms, or some of the key symptoms, and pacing being one of the solutions to kind of help us manage the condition. Obviously, it's just going to mean that some people are going to have a degree of social isolation that might make them even more vulnerable. Again, with the added layer, depending on the privilege that you have, that might allow you to access different social networks. So all this rambling to say that the message is that it's important to recognize the high degree of vulnerability of the person sitting in front of us in a clinical context, but also consider the context in which long haulers find themselves in. So we're not simply looking at, similar individuals. Everyone has a different backgrounds and different experiences that they bring to the healthcare context, and might mean that they are at greater risk of vulnerability, brain fog, right there, live. And might permeate this kind of appointments. And now I pass to Alison.
Okay. So yeah, I suppose there's an aspect of this for me as a patient of something of thinking about, well, what has happened to my own psychology and all of this. And I think there should be some references up there that have helped me to think about it. But more so than any other experience in my life, I have felt so incredibly at sea, lost in my ability to trust my own body. And there's an idea that our body is our home, it's our safe haven, it's what grounds us to reality, it's linked with our ability to know. So that when we as long haulers are already having an uncertain relationship with our body in some way, we're more vulnerable to being gaslit. A challenge from someone else in a particular way can lead you to doubt yourself even more. Sorry, we just got an alert there that the break rooms will be happening shortly. So I'll draw your attention to Dianne O'Leary, who helps us to think a little bit more about the way that might play out for someone and kind of links with some of the power dynamics that happen around it. And then for the clinician, sometimes, of course, it is unintentional, as Diane's slides we're speaking to, but there's huge pressure, speaking as a clinician, there's huge pressure on us. We often have COVID-facing roles where we really don't want to know about the idea of long COVID. We're threatened ourselves. I saw someone in the chat box rightly say that we have a kind of a culture in many of our professions of toughing it out, which links with ableism in society. And there's something about the depth of loss and grief that can come with acquired disability or chronic illness that's very difficult to be in touch with, and that clinicians are humans too. And as a therapist, very often what we're in the business of doing in our own supervision is looking at, how was my tone of voice there? Did I rush to a conclusion too quickly? And was that in and of itself an act of aggression or pushing away some of my own difficult feelings about the person who's sitting in front of me and what they represent? And some of that, I think, can link with another comment in the chat box about, it can be unintentional, this kind of gaslighting, invalidation, but there is actually a violence there too. And sometimes even the word of microaggression isn't sufficient. And ultimately what I feel I've learned from psychological research on this stuff is that people know, they feel it in their bones. In an encounter when you're being invalidated, something switches. And that's something that I've held on to, certainly in some of the experiences I've had where I've not been believed. So without further ado, I believe we're going to get to separate now and talk. Yeah.
Excited. Thanks so much for leading this off. And now we're going to set up the breakout rooms. Technologically, if you look at the bottom of your Zoom screen, right about here, you'll start to see breakout rooms being opened.
And maybe I should just say a couple of words about what we're going to do in the breakout rooms as well before people join.
Oh, thank you.
So yesterday there was a workshop and there were different themes that were being discussed in the different breakout rooms. Here we're going to address the exact same questions, and then we come together and kind of see. I see they've been activated. Kind of see what comes out of the discussion. So I'm going to post the questions that we have in mind to discuss. And then we're going to, divide into the different groups and come back together.
Laura, very happy for you to share your screen if you'd like, because you have the tough job of trying to live animate these summaries. So, Linda, you were in room 1.
I was. So we covered how do we recognise gaslighting, and we had Alison Flynn helping us guide us. And so we had a bit of a brainstorm on what gaslighting is, what does a patient look like who has been gaslighted. So first of all, just reading from this, a patient who has experienced it are often hurt, anger, traumatised, and they lose trust and faith in their healthcare professional. They can lose trust in their body and symptoms that they have. Healthcare professionals are in a position of power, and how they behave is partly how they are trained, but they have our lives in their hands, as one person said, and they are the key to accessing the support and tests and backs up any insurance and disability providers. And we have patients who are vulnerable and lacking that medical knowledge and need their help. And so words can have a big impact. So we also highlighted gaslighting as being obvious and also subtle. Obvious is obviously the gaslighting where you're specifically told you're wrong, you don't have a problem, you're over focusing on your symptoms, There's not a physiological or pathological reason. Normal tests mean there is nothing wrong and you're reassured and discharged instead of being acknowledged and believed. And then there's obviously the more subtle, where it's not always hard to pick up and you don't always notice it while you're in that session. Explanations don't make sense, but you don't fully understand. And you can still be dismissed as a complex patient. And so you don't always get to the bottom of things. And we can also gaslight ourselves and dismiss and deny our own symptoms to make our own situations more easy and comfortable within our friends and society, especially because society's saying it's all over. And we don't want to be that awkward patient, and all the other reasons already discussed, and we don't want to make a fuss. And then we just covered a few things about what we can do, the courage to challenge it and believe yourself and your symptoms. But then one person also flagged up, maybe it's just easier to find a different provider because of energy and time constraints. And then, as Dr. Patino said earlier, asking your doctor the questions about how they came to a diagnosis with those symptoms and how they ruled out all the other differential diagnosis, and giving clear bullet points to your physician. And if we see it as a healthcare professional, do we need to call it out using current research about symptoms correlating with lab tests like Dr. Petrino showed, to flag it up as that healthcare professional finding it.
Amazing summary. Thank you, Linda.
Thank you.
We've got 1 minute of this section. So, Alison, anything you wanted to add extra to that summary?
I don't know. I sort of want to open the floor to everyone again. I guess for me as a person with long COVID, this experience, these conversations I've had today, but also being part of the entire forum that you've organized, has felt like an incredibly healing thing for me. On Wednesday, I had a very invalidating experience with a locum physician, and it left me feeling awful. And there's something about coming to something like this, and although you can intellectually have the knowledge about a topic like gaslighting, the emotional aspect of it and the healing that comes from these kinds of experiences, I think, really only come from being able to talk and connect with people who understand and have similar experiences, or clinicians who get it. So that's
Thank you.
kind of the main thing I've been thinking.
Thank you for sharing that. Again, the theme of connecting to create change. We're creating change right now through our connections. So thank you. Jessica, summary from room 2.
So we had a pretty organic conversation, I'd say, that just kind of flowed and didn't necessarily answer the questions in any particular order. So I'm just going to kind of chat about what things I could pick up on. There was lots of great comments in the chat box, so it was a little bit difficult to pick up on everything. But one of the first one was the challenge in approaching colleagues who are gaslighting and are totally unaware of it, thinking they are fully validating a patient or colleague. And we're going to kind of circle back to that theme too. It's hard to recognize it in the moment. Realizing gaslighting has happened comes afterwards. And that cognitive impairment can affect the ability to communicate during an appointment. And this can affect your ability to be heard, especially when there are time constraints. And then again, that not realizing until afterwards that things didn't go the way you had expected. Medical professionals gaslight without even realizing it. There's an emphasis on reassuring people and discharging them. They have a duty to get patients to accept that there is nothing wrong. They aren't meaning to, but it's embedded in profession. There, again, this theme of being embedded in medical training, that there's a cookbook for how to dismiss patients. Assad mentioned the patients who won't behave is an actual workshop title. Doctors want to apply Occam's razor. The simplest explanation is the best. There are red flags in the medical professionals of trying to label people as fabricating things. So if you're homeschooling or understanding of medical terminology, these can sometimes raise points in negative points, I guess, from the medical professionals. Oftentimes, emotions are misinterpreted as depression. So crying does not equal anxiety or depression. but it's often interpreted as that. Being gaslit makes it difficult to trust anyone in the future, and they're often seen as non-compliant. Due to post-exertional malaise, post-exertional symptom exacerbation, and episodic nature of long COVID, often you show up well to appointments, but then it's because you rested before and really rested afterwards, and you get the comment of, well, you look good. So yeah, that was kind of a big theme, and just a couple of points about strategies used to address it, because I think that's really important here, is having someone come with you to appointments, an ally to help neutralize the threat or help to communicate as well, getting a second opinion, bringing in information or research papers to appointments to back up your points. On the flip side of that, someone commented, I have found that the less I say, the kinder the healthcare professional is. They don't want to hear any thoughts or knowledge sharing, which makes me feel alienated from my own care path. So really interesting on both sides there. There was talk of the broken record strategy. So repeat calmly and politely the same thing over and over. I think one of the biggest thing was the larger picture is that there needs to be a change in the power relationship between healthcare professionals and patients. There needs to be more empathetic training, health coaching in the medical field in general. So again, all of this discussion is big picture thinking really about the changes that need to happen on that in the healthcare landscape, I'd say. The last point I would say is to get things in writing or communicate in writing as well, so that you have, first of all, that may help cognitively, but then you also have things documented.
For your exceptional scribing skills. We've probably got 30 seconds left of this session. Ana, any parting remarks?
There's a lot of power in community. And, this is a collective problem, is not an individual problem. And, other people have mentioned this in our breakout room, but as we all recover and go back to our workspaces and professions, I think, we have a collective voice now, and we have gathered all this knowledge in this space and other spaces that we can push for change, I would say. I think gaslighting is definitely not an individual problem. 30 seconds.
Brilliant. Thank you, Alison. Thank you, Ana. Thank you to everybody that contributed to this session. The power of workshops in action, connecting to create change.